When we talk about altering the immune system, there's really two branches in terms of drug therapy. We've got the non-steroidal anti-inflammatory drugs, okay, like ibuprofen, aspirin, and so forth. And we've got the steroidal anti-inflammatory drugs, and that's what we're going to talk about today. And in keeping with the theme, you know, since this is Greco-Roman columns, I've got something from 300 here, which was an awesome movie. After I watched that movie, I started doing sit-ups for like 2 days, and then I gave up. But you know, essentially, I think this is a poor Persian guy, but he's the enemy, and he's the symbol of inflammation. And so what we're doing here is we're looking at kind of the steroidal anti-inflammatory drugs, the glucocorticoids. Okay, and so when we talk about steroids, we're talking about long-chain carbon molecules, okay, and there's really two types. There's androgens, okay, and those have 19 carbon molecules, and there's corticosteroids, which have 21, all right? And so the corticosteroids are further divided into glucocorticoids and mineralocorticoids based on their physiologic functions or physiologic outcomes. And both these two are made within the adrenal cortex, okay? And also remember that the backbone of androgens, of steroids, is cholesterol, right? And so that's kind of the building block, excuse me, molecule that the body uses to actually make some of these molecules. And so remember, here's the first drug to kind of be aware of is Aminoglutethimide. And so this essentially inhibits the conversion of cholesterol to Pregnalone, which is kind of the first step. And it's actually the rate-limiting step in terms of glucocorticoid and mineralocorticoid synthesis. And so the activity of that is really dependent on ACTH, adrenocorticotropic hormone. Okay, and so here's the synthetic pathway of all these glucocorticoids and mineralocorticoids, starting with, of course, cholesterol converted to Pregnalone. And then you can see there's a testosterone-type molecule that eventually gets converted into cortisol, and then other Pregnalone-like molecules that eventually become something like aldosterone. Okay, and so this is kind of the review of systems in terms of the biochemistry. I don't think you need to know all of these different steps, but you know, we will make reference to certain enzymes that are responsible for the conversion of some of these molecules to a different molecule. And notice here, what are these enzymes? Again, they're CYP enzymes. And so it's that cytochrome P450 system. These are different enzymes that have been involved with our drug biotransformation. Okay, and so we'll start reviewing concepts now throughout pharmacology. What are the two CYP enzymes that we associate with drug biotransformation? CYP3A4, and then the other one is CYP2D6. Yeah, perfect. So CYP3A4 and 2D6 are really the kind of the main CYP metabolizing enzymes responsible for probably 2/3 to 3/4 of all the drugs that are biotransformed. CYP3A4, remember, is the one that's inducible, right? CYP2D6, not necessarily inducible, but has altering genetic profiles in terms of populations of people, so racial and ethnic differences. We've got people that metabolize it very well, people that metabolize it very poorly, okay? So here's all your CYP enzymes. And so we've got a few drugs that can inhibit some of these specific cascades, and we'll talk about those specifics. And so let's review a little bit of the physiology of the adrenal cortex, right? And so there's ACTH hitting this gland. And so these glucocorticoids are really derived from the cortex portion of the adrenal gland itself. Then remember the sex hormones like androgens and estrogens to some extent are coming out of the zona reticularis. And of course, remember, we talked about the adrenal medulla and the process of catecholamine synthesis. And remember, that's kind of the main organ where epinephrine is being released, right? And so it takes, there is some norepinephrine release, as the image suggests, but the bulk of the body's epinephrine is coming from the further one-step synthetic pathway of converting norepinephrine into epinephrine, and that occurs here as well. So, you know, obviously the adrenal gland is really important in terms of, oh, and of course the mineralocorticoids, aldosterone, is coming from the outer portion of the capsule. And so you've got a whole bunch of physiologically altering hormones that are coming out of this gland, and of course all of these things can be potential drug targets. So there's a feedback loop that exists, and I'm sure you're all familiar with this. This is just a review of biology. Here you've got the hypothalamus secreting corticotropin-releasing hormone or corticotropin-releasing factor, same thing, hitting the adenohypophysis, which is going to produce ACTH, and that's going to stimulate the adrenal cortex to produce cortisol. And of course, cortisol has a negative feedback loop, and ACTH coming from the adenohypophysis has a negative feedback loop going back to the hypothalamus. All right? And this basically just shows the same thing. So a little bit of background. Glucocorticoids reflect their carbohydrate regulating actions, and so they're going to regulate things like glucose. All right? The prototype compound in this category is cortisol or hydrocortisone. Okay, so now you can start putting the drug classes in baskets. What are the physiological effects? It's going to obviously alter metabolism. It's going to stimulate insulin release. It's going to stimulate lipogenesis. Okay, and it'll basically produce fat deposition. So what do you think the major side effect to glucocorticoids are? Increase in body mass, weight gain, and so forth. And so think about a patient population. What type of patients would be really benefited by having extra weight? Cancer patients, right? They don't want to eat, right? So one of the side effects to the glucocorticoid adjuvant therapy is actually weight gain and appetite stimulation for these patients, which actually isn't a bad thing. They also have a tendency to regulate inflammation, and so that's why we can use them in several disease states, right? So we can reduce the concentration and the distribution of leukocytes. Okay, we can reduce the activity of antigen-presenting cells, APCs, like macrophages. That symbol's the international symbol for macrophage, remember? And we can reduce phospholipase A2, which is one of those kind of pro-inflammatory enzymes that's coming off of arachidonic acid metabolism. This is in contrast to mineral allocorticoids, which essentially reflect their electrolyte regulating activity. And so the prototype here is aldosterone. And we learned about aldosterone and its effects in the renal component of this course, and we'll kind of revisit some of that in terms of what it does in the periphery. In terms of regulation, we talked about how it can regulate sodium of water, and we've talked about how ACTH regulates some of the secretion in the adrenal glands. Also note, angiotensin can produce or stimulate aldosterone release. And so, again, another kind of a outcome to ACE activity is this enhanced aldosterone release. And so now you can kind of see why an ACE inhibitor in something like spironolactone might work synergistically, okay? Here's the mechanism of action of how some of these drugs work in terms of the glucocorticoid receptor. Essentially, this is a genetic alteration. And so the whole concept of these pro-inflammatory effector cells, T cells, B cells, chemokines, macrophages, all of this has a genetic component, right? These are genes that beget protein, that alter signaling, and alter the immune cell activity. What glucocorticoids do is they actually inhibit the transcription, okay, of some of these pro-inflammatory genes. All right? And so that's basically the mechanism. You can see here they couple, here's the glucocorticoid, and then here's the receptor. Becomes internalized and moves into the nucleus, and then it actually alters transcription. Okay? And so it's going to regulate gene expression. So here you've got the drug receptor complex forms, and this is describing the same thing that I just showed graphically. You've got the drug receptor complex being formed, okay? You've got translocation of that drug receptor complex from the cell membrane into the nucleus, okay? And it's going to bind to what's called glucocorticoid response elements within the DNA sequence. These are called GRE, okay? And that's going to activate the transcription or metabolic effects. Okay, so it's twofold. It can either activate transcription or it could inhibit transcription, okay, depending on what it does to the activity of the promoter. Okay, what's the take-home message here is that the glucocorticoid is altering gene transcription. And alter is probably the safest word because there are certain genes that are turned on, certain genes that are turned off because of what this thing does to the promoter region. Okay, that's as far as we're going to go into it. And so when we talk about the inhibitory effects, we're going to really kind of inhibit the transcription of genes that regulate immune suppression or genes that are anti-inflammatory. And so some of the examples include the steroid hormones, thyroid hormones, vitamin D, and retinoids. Okay? The mineralocorticoids actually work through a very similar mechanism. These work through the drug receptor complex called the MR complex for mineralocorticoid. And this complex expression is kind of privy to specific tissues. And so you'll see it in the kidney, the colon, salivary, and sweat glands, okay? And so, of course, aldosterone, which is kind of the prototypical agonist in all of these examples, actually has the dramatic effect within the kidney because the kidney has a lot of mineralocorticoids receptor complexes where this can occur. And so we know that we see an increased sodium influx due to this MR binding, which is going to actually stimulate that sodium-potassium ATPase pump on the basolateral membrane. Okay, and so, you know, mechanistically, how do these drugs work? They're going to alter gene transcription. Okay, and depending on what gene you're looking at, and they alter a lot of them, you can see, you can produce a stimulatory or an inhibitory effect. Okay? And so this is kind of just describing that in a little bit more detail. And remember, the things that basically stimulate the hypothalamus to secrete CRH could be a whole host of neurotransmitters. And here you've got acetylcholine, 5-HT, remember, serotonin, NE is norepinephrine, and GABA is GABA, glutarol aminobenzoic acid. And so all these things can positively or negatively affect the hypothalamus pituitary complex. Okay, and so, of course, what's the outcome here is that we're altering the activity of the immune system, right? Because we're talking about glucocorticoids as being steroidal anti-inflammatory drugs. And so, have any of you ever taken steroids? Right? What would you take them for? Inflammation, pain, swelling, you know, post-procedure. You know, so there's a whole host of indications for these drugs. We've looked at glucocorticoids in terms of clinical outcomes, and there's a few things to remember is that they're palliative. Okay, so they don't address the underlying cause. So they don't cure the reason that you have inflammation, right? They just reduce the intensity of the inflammation. Okay, so the inflammatory cascade is going to happen no matter what. They're just there to attenuate it. Okay, and so we can see their clinical use in specific examples where you can see them used in early parts of the disease, and we can also see them used in later parts of the disease. And so, of course, the immune system is persistent throughout. And so we're altering or we're targeting different components of the immune system or different facets of the immune system to address each of those phases of a specific disease. Okay? We know that they can, as a group, they can increase apoptosis in activated lymphocytes, and so that's their immunosuppressive action. They inhibit chemokine or cytokine production, and so these chemokines and cytokines are the things that are put into the circulation that are basically driving leukocyte recruitment and migration from one anatomical compartment to another. There's some idea that they can also be used to be antiemetics, and so they can inhibit vomiting, but we're not really sure how. And we see them used almost exclusively for adjuvant therapy for during surgery, during chemotherapy. We can use them for analgesia. We can stimulate the appetite, especially in cancer patients. And we can alter gene expression of 10 to 20% of all genes. Okay? And so, you know, lots of different outcomes, lots of clinical uses for these drugs as a whole. You can also see them used in rheumatoid disorders that have a collagen component. Okay, allergic symptoms like angioedema, contact dermatitis, okay, non-fever producing inflammation, drug hypersensitivity reactions, acute episodes of asthma, which is why they put some of them in here, ulcerative colitis and so on, organ transplants, endocrine disorders, leukemias, lymphomas, and cancers. And so pretty much anything that's wrong with you, you could probably take a glucocorticoid and you'd probably be okay, right? So let's talk about some individual drugs. We'll start with glucocorticoids as a group. And remember, the prototype here is hydrocortisone. Okay? This lecture is not that bad because there's only a handful of drugs, and they all pretty much work the same. The only thing that's different is the indication and the relative potency. Okay? Hydrocortisone, we've all taken hydrocortisone, right? Poison ivy, a tick bite, a mosquito bite, eczema, psoriasis, whatever, right? We've all had hydrocortisone. It's over the counter. There's a picture of it. It's a topical cream. You can use it for itching, redness, swelling, and so forth. It's available OTC at 1%, and you can also write a prescription for it, getting 2.5 or 3% hydrocortisone. In terms of people that have persistent arthritis, you can still see hydrocortisone being injected into the inflamed joint for acute relief of joint pain. And you can also see it prescribed orally for systemic administration for patients that have various types of adrenal insufficiencies. Okay? The asthmatic patients, and so the lung component, glucocorticoids as a group, particularly hydrocortisone, can actually reduce airway inflammation during periods where this asthma is exacerbated or made worse in an acute phase. And we'll talk about that in a couple hours. There's co-infections with viruses and bacteria, patients that are coughing for wheezing and seasonal allergies. This can also be helpful. And actually, hydrocortisone can be used as a rectal suppository for hemorrhoids due to swelling and itching of the anus. And so tons of different indications for hydrocortisone. It's one of the drugs that's supposed to be in every pharmacy, and it's on the World Health Organization's list of essential drugs for patients. Okay? So kind of going along further, there's cortisone. Okay, and so it's pretty similar to hydrocortisone. Structurally there's less water in it. It's a synthetic 21-carbon steroid hormone. Okay, and this is coming from the adrenal gland. You can get preparations for oral or intramuscular. It can be orally administered, or it can be prepared for intramuscular injection. Tons of endocrine disorders and inflammatory or fever type of manifestations. And there's the mechanism, essentially, what we've already talked about. The outcome here is that with cortisone and some of these other cortisone derivatives is that we're going to see a reduction of several what's called pro-inflammatory cytokines. And so IL-2, IL-1, IL-6, tumor necrosis factor alpha, TNFA. All of these are kind of pro-inflammatory cytokines, and so when you reduce their activity, you kind of restrict or reduce the inflammatory cascade. Cortisone has hepatic bile transformation if it's orally administered, and it's also got renal elimination. And the side effects and the adverse effects include reduction in bone formation, suppression of calcium absorption. So what does that tell you? It's got a little bit of mineralocorticoid activity, right? Because these are all essentially glucocorticoids in this particular portion of the lecture. And they've got reduced or delayed wound healing. So why would you expect that? If you give steroids for a week, why would you expect the patient that has a cut on their finger to have reduced wound healing? What are you inhibiting? You're inhibiting the pro-inflammatory immune system cascade, right? And so you need the inflammatory cascade to actually address wound healing, and so now you're systemically suppressing it for that short period of time. And so, patients that are on persistent cycles of corticosteroids will notice, a dramatic reduction in their ability to kind of repair wounds. So even a minor cut on their finger would take, maybe 2 weeks to heal as opposed to 3 or 4 days. Probably the more famous or more commonly encountered corticosteroid is methylprednisolone. You guys ever take a Medrol dose pack, shown here on the right? The first day it's six tablets, the second day it's 5 tablets, and then each day you taper off. And so what we use this for is a whole host of things. I actually had Medrol for a wisdom tooth extraction. So they know that when you do a wisdom tooth extraction, you're going to have a lot of inflammation, especially localized, right? And so they'll give you the Medrol dose pack to start taking, I think, usually before the wisdom tooth is extracted, and it kind of reduces the inflammation. And so, when you get your wisdom teeth taken out, your whole face swells up like a balloon. This kind of alleviates that to somewhat extent. You can also see methylprednisolone or Medrol dose packs in spinal inflammation, and so patients that have back pain or back injury, joint pain, arthritis, lupus is going to keep coming up for the next 4 hours. Medrol dose pack can be used for any of those. Okay, you can also get it in a liquid preparation where you can actually inject it into the spine, and that's part of an epidural in some minor procedures in the hospital. It does have good oral absorption. It also has hepatic bile transformation with renal excretion. And so the duration of activity kind of depends on where you put it. If you put it in the mouth or in the back or in a joint, it's going to have a different duration of activity. If it's given IV, The duration of activity is about an hour. If it's intra-articular, so within a joint, it's going to be about a week. So obviously a huge discrepancy there. And specific dosing criteria is based on, one, the age of the patient, and then two, where this inflammation is. Okay? Prednisone and prednisolone are essentially the same drug. You'll find out why. They predominantly have glucocorticoid properties. And so what are they indicated for? Well, I'm not going to read all that, but you can pretty much any kind of, bless you, pretty much any disease you could possibly make up, you can use prednisone. And we've talked about using prednisone as an adjuvant in chemotherapy, and you can also see it, all the indications here. It's an anti-inflammatory agent. It has both oral and IV administration, depending on where you're at and what you're trying to use it for. Prednisone can inhibit leukocyte infiltration, and so if leukocyte infiltration into a wound is a good thing, right, in an acute wound healing phase, prednisone probably would hamper that. If leukocyte infiltration is a bad thing, prednisone would be a great drug for that. Where would you want to inhibit leukocyte infiltration? Right, that's a natural disease process, right? Where would you want to inhibit it, though, just theoretically? Brain? Okay, that's good. Where else would leukocytes be kind of problematic? Bone marrow? How about if an organ transplant? Do you want leukocytes in there? No. I don't know if we talked about tumor biology to an extent, but it's been shown that infiltrating leukocytes may or may not have a good clinical scenario or good clinical outcome. Some patients that have a huge influx of immune cells into their tumor have really good responses, depending on the tumor type. And then some patients that have an influx of immune cells into their tumor have really, really bad responses, again, depending on the tumor type. We don't know that dichotomy yet, which is probably why it's not in the curriculum. But there are instances where you have an influx of immune cells. Yeah, that's a bad thing. You want to stop that. Okay. Think about it even more realistically. Think about a hip replacement, right? Do you want an immune reaction in a new hip replacement? No, you kind of want to suppress that a little bit too. So, there are instances where you'd want to momentarily reduce or restrict the flow of immune cells to an anatomic location. And that's actually kind of going to be the theme for today, is that maybe up until now you've been thinking about the immune system as your friend. Today we're going to view your immune system as kind of your enemy, okay, and how it's going to actually promote disease instead of actually cure it. What's the difference between these two? Prednisone is the prodrug, and prednisolone is the pharmacologically active version. So that's all the only difference there. You probably had triamcinolone at some point in your life. It's got a whole different host of indications, but it can be administered orally, topically, or via injection. Okay. Or the oral dose I forgot to put there, but that's fine. It doesn't matter because we don't really ask dosages anyway. Topical cream, we can actually get really nice delivery to the skin, more so than oral prednisone. Okay, so why would you want to use a topical glucocorticosteroid? How about itching? Poison ivy? Poison sumac? If you're allergic to nickel and you accidentally buy like a nickel piece of jewelry, right? Psoriasis, bee stings. Even if you're not allergic, a bee sting is an inflammatory thing, right? So those are the types of things that you can see. It has been used as an epidural into the spine. It's also part of the inhalation therapy for asthmatic patients, but it's really useful for dermatology as well. And so you can also see combined with nystatin cream, right? So if the patient has a fungal infection, a topical fungal infection, the nystatin is going to actually address the fungal infection, right? What's the triamcinolone going to do? It's going to treat the itching, right? And so you don't want the patient to be scratching this fungal infection, because then now it can open up the layers of the dermis and it can move down, or move in, I should say. Okay, so a lot of indications. Betamethasone is different chemically. It's got 21 carbons, all right? Mechanistically, we say it's a glucocorticoid receptor agonist. And what's it indicated for? Itching, dryness, inflammation of the skin if it's topically administered, respiratory diseases, rheumatic disorders, collagen diseases, tuberculosis within the meninges, and trichinosis. Right? So lots of indications with dexamethasone, or with betamethasone. Also dexamethasone, its cousin, also 21 carbon. Okay? Lots of indications listed here. Hepatic bowel transformation if it's given orally, high degree of protein binding. We can use dexamethasone in the diagnosis of Cushing's disease, which we'll talk about at the end of this lecture. And it's a more potent corticosteroid in terms of its anti-inflammatory properties. Okay? So what does that mean? So structurally, they all look alike chemically. All right? And so the anti-inflammatory properties are essentially synonymous with the glucocorticoid mechanism that we described earlier. The mineralocorticoid mechanism is essentially talking about the sodium-altering activity, specifically at the site of the nephron, right? So some of these drugs have a little bit of mixed activity. So hydrocortisone, for example, has an anti-inflammatory activity of about a 1, but a mineralocorticoid activity also about a 1, right? So it's essentially equal. This is in contrast to something like dexamethasone, and betamethasone, which are very, very potent anti-inflammatory drugs, and essentially no activity in terms of altering electrolytes on the nephron. Okay? That was all the glucocorticoids. What are they basically used for? Reduction in inflammation, right? Mineralocorticoids, like aldosterone, we'll talk about now. There's only a handful. Fludrocortisone is also a 21 carbon molecule. Mechanistically, this is a synthetic mineralocorticoid receptor, aldosterone receptor. It causes an increase in iron and water transport, and it's a more potent mineralocorticoid. What happens here, you've got a raise in the extracellular fluid volume and blood pressure, and you got lower potassium levels. Okay, and so what kind of patients use it? Well, patients that actually have adrenal insufficiencies, like Addison's disease, and they've got a salt-losing adrenal genital syndrome. That's a component of that. It's got both hepatic and renal bowel transformation, and the physiological actions are similar to that of hydrocortisone and are summarized right here. Talked about spironolactone, right? Here we've got a competitive aldosterone receptor antagonist, right? So it's going to block this. It's basically the drug of choice for bilateral adrenal hyperplasia, all right? And it persists in the system for a long time. So, once you stop giving that drug, you've got to wait about 2 to 3 days before that drug is essentially eliminated, and so long half-life. We can also use it diagnostically for the primary hyperaldosteronism, and it's got a whole bunch of indications. And so if the patient's got edema for any of those reasons, ascites, nephrotic syndrome, cirrhosis, spironolactone is a great drug. Okay, you can also talk about it, we've talked about this in hypertension, heart failure, and there's also some off-label indications, acne and excessive hair growth, especially in women. And so, lots of indications for spironolactone, and it's all basically coming from that mineralocorticoid receptor antagonism. Okay, so let's kind of just review these glucocorticoids, all right? Here you've got the short-acting, intermediate, and long-acting glucocorticoids, right? So the short-acting ones are essentially hydrocortisone and cortisone, intermediate-acting, prednisone, methylprednisone, and triamcinolone, and the long-acting, which are actually the most potent, betamethasone and dexamethasone, right? Relatively straightforward. Okay. And so up until now, we've been talking about inhibiting the activity or altering the activity of genetic response elements, okay? Now we can actually go after steroid synthesis inhibition. So this is, outside of that, and we're going to actually inhibit these steroids to be made. And so that first drug that we talked about was aminoglutethimide. And so this one's going to inhibit the conversion of cholesterol to ACTH, right? And the reason that that's important is because the main building block, Pregnalone, is essentially the skeleton for all of these hormonally dependent cancers, because it's going to be the building block for androgens. Sometimes you can see aminoglutethimide combined with hydrocortisone, okay, and that'll basically offer replacement doses in patients that have insufficiencies. And the results of this is going to be all hormonally active steroids are going to be inhibited because of the CYP11A1 inhibition, right? So what does that mean? Well, cancers that are really dependent on hormones for their survival are going to be really affected, right? So breast and prostate, essentially. Interestingly, aminoglutethimide is kind of sloppy. It also inhibits CYP11B1 and CYP19, which we didn't really talk about. But that's basically two other biotransformation type enzymes. Oh, my machine just went black. There we go. One more time. Wake up. God, I even put the machine to sleep. There we go. And interestingly, we don't really know how, but aminoglutethimide has some anticonvulsant properties too. It does have some abuse potential. And this is interesting. Bodybuilders have been doping with aminoglutethimide because essentially what it's going to do is it's going to lower the circulating levels of cortisol, okay? And that's actually going to prevent or inhibit muscle loss. Okay, so when they do those, when the Olympic screeners start looking at the athletes, aminoglutethimide use is part of that test that they give them to see if they've been quote unquote doping. And also drug abusers have, they're very good chemists. They've noticed that aminoglutethimide has the ability to induce CYP2D6. Notice this is not CYP2D4, which we said was non-inducible. CYP2D6 is inducible, and it's really the one that converts codeine to morphine. And so you can see how that could be exploited if you were a drug-seeking addict, specifically for morphine. Metirapine, no, it's metirapine. Metirapine is how it's pronounced. Inhibits 11B hydroxylation. What's going to happen here? It's going to interfere with cortisol and corticosteroid synthesis. And so that's basically the treatment for Cushing's disease, and we'll talk about that in a few minutes. Here you can kind of test or perturb the integrity of that feedback loop, and you can kind of see where that feedback loop is being inhibited. Is it a hypothalamus problem, or is it an adenohypophysis problem? Okay. The only problem here the only side effect here with metirapine is going to produce transient dizziness and GI disturbances. Okay, and here's metirapine, I should say. Basically, if you inhibit 11-beta hydroxylase, you're going to reduce the production of both cortisol and aldosterone. A drug that we've talked about before is ketoconazole. And this is kind of a weird drug. First of all, it's an antifungal, okay, at normal doses, okay? But at high doses, overdoses, or in pharmacodynamic interactions, it can actually inhibit both adrenal and gonadal steroidogenesis, okay, because basically it has activity for CYP17, also known as 17-alpha hydroxylase, right? So, ketoconazole keeps coming up. I know it's in your board review books. It also has a pharmacodynamic interaction because of its activity on CYP3A4, okay? So it's a substrate, I think, for CYP3A4. So lots of drug-drug interactions. If a patient's on ketoconazole and they're older, you should probably look up the drug interaction because I'm sure that one exists. What's interesting in terms of ketoconazole is at high doses, it inhibits CYP11A, and so you're going to block steroidogenesis in these steroidogenic tissues. What are the adverse reactions going to be? GI upset, dermatologic reactions, liver function tests are going to be needed to monitor this because this is going to actually kind of be really, really bad. The benefits are observed after several weeks of therapy. So, it's not really a great corticosteroid, but it actually kind of behaves like one. And so when would this ever come up? Well, think about a patient who's on, long-term ketoconazole therapy for a persistent fungal infection. You can actually start to see changes in hormones because of that. Okay, and so that's one other thing to think about, especially if that patient's prepubescent. And so the long list of side effects and toxicities, and so this isn't for ketoconazole, this is for all of the drugs that we've been talking about. Virtually no side effects or toxicities within a week, right? So what does that mean? So, go back to the patient that received that Medrol dose pack for their wisdom tooth extraction. they're only on it for, I think, 6 days actually, right? So they're not really going to have some of these side effects that we're going to talk about further down, all right? What kind of patients are going to be on these types of drugs for long periods of time? Well, we kind of highlighted a few of them. Patients that are on persistent immunosuppression for maybe a transplant. So think of a lung transplant. You'll be on persistent immune suppression for a long time. Chemotherapy, they're already immune suppressed, but you're also combining the glucocorticoids to kind of reduce some of these inflammatory components. Okay. And then of course patients that have the adrenal insufficiencies like Cushing's and Addison's disease, right? These patients are going to be on long-term glucocorticosteroids. Okay. So abrupt withdrawal after prolonged use is actually going to be associated with an adrenal insufficiency, and that can actually be fatal. Okay. And so we're also going to alter carbohydrate and protein metabolism. We're going to redistribute fat, and we see this actually in the context of Cushing's that we'll talk about. They have kind of more fat on the back of their neck, and that produces something that looks or resembles like a buffalo hump. Okay. It's a common cause of drug-induced diabetes, muscle and joint stress with prolonged use. Why is that a problem? Well, if the patient was using it because of persistent joint pain, they can actually develop muscle and joint pain because of that. So you can't overuse these drugs. And of course, whatever discipline you go into, there's guidelines for how frequent you can give a steroid injection into an inflamed joint. You wouldn't do this every day, maybe every quarter, every 2 to 3 months, right? And there's more, so see the course notes for a complete list of side effects and toxicities. This is just a sprinkling of things that I just grabbed from the course notes. Okay, and so with steroid treatment, like all drugs, you're really looking at the risk-benefit ratio, right? And so, if the cortisol treatment is too low, and so this is kind of going back to the adrenal insufficiencies, which we're getting into right now. If cortisol is too low, these are the things that the patients will present with, okay? Hairiness, acne, greasy skin, irregular periods, reduced fertility, tiredness, fatigue. If cortisol treatment is too high, we're looking at increased appetite, weight gain, muscle weakness, thin skin, easily bruising, possibly high blood pressure, osteoporosis, and an exacerbation of diabetes, right? So all of these things sound extremely unpleasant. Right? So you want to make sure that the patients are kind of within that therapeutic range of not too much, but not too little. Okay? And so this basically summarizes the glucocorticoid effects in terms of their physiological effect and their pharmacologic effect. You can just kind of review on your own. All right. So let's go back a little bit. Cortisol, what is it? We said it's released from the adrenal cortex in response to ACTH. All right. The reason it does this is, well, a few reasons. One, we're going to ensure that there's adequate glucose coming to the brain, all right, which is required for gluconeogenesis and glycogen synthesis. And the enhancement is going to be muscle and lipid breakdown. So when you have a disease in terms of cortisol activity, okay, you're going to see changes in those things that we just described. And so Addison's disease is basically low cortisol levels, and Cushing's disease is the opposite. It's high cortisol levels. Okay. Let's go to Cushing's really quick. So Cushing's disease and Cushing's syndrome are essentially extensions of each other. Cushing's syndrome is defined as bilateral adrenal hyperplasia secondary to an ACTH secreting primary adenoma. What does that mean? Well, you've got adrenal hyperplasia and lots of ACTH being produced. And so, the adeno hypophysis is just spewing out, spewing out ACTH, okay? And of course, then the adrenal cortex feeds into that and makes more cortisol in response to that. And so here you have hypercorticism, okay? And that's basically the etiology. And so we need to treat Cushing's, basically because it can lead to diabetes, it can lead to cardiovascular events, it can also lead to electrolyte abnormalities. So what's the treatment? Well, if it's a tumor, right, and if it's secreting too much, what do? When in doubt, cut it out, right? So surgery, and then of course we'll have to do pharmacological adjuvant therapy as well. There are some patients who cannot receive the operation for a variety of reasons, their health and so forth. And there are some patients who are refractory. So even in spite of removing this tumor, it can maybe return, or they just don't respond well. And so they'll need some pharmacologic management for them. Okay, so how do we diagnose it? Well, we look at the dexamethasone suppression test. And so there's basically two ways you can do this. One is a low dose test, which is described here. One is a higher dose test, which is described here. Probably the most famous person that I could find that we think may have had Cushing's disease was King Henry VIII, who was, kind of a nice guy. That was a joke, he wasn't a nice guy. This is in contrast to Addison's disease. And so here we've got a primary adrenal cortical insufficiency, which is autoimmune in nature. And so the outcome here is that essentially it's a non-functional adrenal cortex. Okay, and so what's the result of that? We're going to have loss of activity in terms of cortisol, aldosterone, as well as androgens. And so the characteristic here is got low cortisol, very little cortisol coming out, and high ACTH, because remember it's negative feedback. And so if you reduce this pool, right, the feedback brakes are removed, and so the adenohypophysis spits out tons of ACTH to try to stimulate the adrenal cortex, and nothing comes out. And so the pathology is right here within the adrenal cortex. All right. Here we see pituitary increases in ACTH that basically try to stimulate that, and it doesn't happen. And so the symptoms include weakness, fatigue, hypotension, hypoglycemia, sodium wasting, depression, apathy, psychosis, and then hyperpigmentation. Okay, so obviously not pleasant. Probably the most famous person that had Addison's disease, and it was kept quiet for a long time, was JFK. Okay, and he actually kind of had the prototypical moon face, and so that's basically just this this half-round kind of puffy face, and they contributed that to, he looked very young when he was competing against Nixon, and so they think that his Addison's may have actually helped him. But if Addison's progresses and it's not treated, these are the types of patients that start to look like, they start to get very thin, they have kind of poor posture, they also have postural hypotension, hypoglycemic, their skin looks a little bronzed. And so I don't know if you remember the presidential debate between Nixon and JFK. Of course, it was in black and white, so you couldn't tell, but people that were there saw that Nixon looked comparatively pale, and JFK looked much more tan, even though he hadn't been out in the sun. It was probably due to his little bit of hyperpigmentation of his skin. So, pretty interesting story. There's a secondary adrenal cortical insufficiency, and so this comes from long-term steroid use, basically for patients that have rheumatoid arthritis, right? And so we talked about, most patients that receive steroids are receiving them, for minor acute type inflammatory events. These patients, that have RA, they're on long-term immunosuppressants, okay? And steroids is just one part of their therapy. They're on a few others, which we'll talk about in a few hours. This HPA axis is suppressed, of course, and so here we've got, again, low cortisol, but in this context, we have low ACTH. So what does that mean? Well, the pathology is no longer here. The pathology is here. So the adenohypophysis is the source of the pathology. And so here you've got very little ACTH coming out, and because of that, the adrenal cortex is essentially okay, but it's not making a lot of cortisol because this is, the positive or the negative feedback loop has been hampered. And so the outcome here is going to be very low amounts of cortisol coming out. Okay. And so we can also use steroids in diagnostic medicine as well. And so I think it just gives it good credence to probably talk about the dexamethasone suppression test. And so essentially what you're looking at is you're using a potent glucocorticoid like dexamethasone to basically suppress this activity. And so this is how the test works. And what's the outcome here is that, well, you can actually challenge the system and look at the feedback, within a specific time frame, and you can determine whether or not the patient has Cushing's. And so if this plasma cortisol measurement at 8 a.m. is well over 10 milligrams per deciliter, you can say that borderline Cushing's patients are going to remain pretty high, right? Most people will be able to suppress this challenge, and these cortisol levels should fall within that time frame. Okay, so that's basically how this test works. There's another version of this test as well, which you can read about, but I just thought I'd put it in because it's one of the few times we actually use a drug to diagnose a disease, and I think that that's kind of cool. But this unit is about lung physiology, right? And so let's go to steroids and their use in pulmonary conditions. Steroids are great in terms of asthma and COPD, okay? And so we know that severe asthma attacks are going to require hospitalization, but some of these oral agents, some of these oral steroid agents have been replaced by inhaled corticosteroids, which we'll talk about in the asthma chapter, in the asthma lecture in a couple hours. And so all of these drugs, which are steroids, of course, actually have really good use in asthma, okay? And so what does that tell you? How are they delivered? Systemically or via inhalant? Inhalant, yeah, which is why they're not in this lecture, okay? So how many ways now can we deliver steroids? We can do oral, we can intra-articular, like into a joint, IV, and now in an inhaler format, okay? And so these are the ones that you'll see in an inhaler formulation. And of course, you know, we can talk about anabolic steroids. These are obviously different, and it's been shown to have a clear benefit in patients in terms of building muscle mass. Obviously, the Olympic teams, some of them were accused of doping their members with some of these steroids to improve performance, say that 10 times fast. And of course, androgens, i.e. testosterone, made in the testes, basically gets converted to estrogen or DHT. And so the clinical use here, you know, aside from the fact that, you know, some of these athletes just want to be stronger, faster, bigger than their competitors, they actually do have some clinical use. We can see them used in cancer patients and HIV patients for growth and appetite suppression, stimulation. We can treat wasting syndromes that are associated with those patients as well. In patients that have delayed puberty, we can see these drugs being used to induce puberty. And of course, there are some men who have low levels of testosterone or low libido because of that, and so we can replace their levels and kind of bring them up to normal levels so that they don't experience some of those side effects. Side effects include aggression. So what does testosterone do, right? It makes you aggressive, it makes you hungry. There's going to be increased cardiac events like MI and CAD, acne, and of course, because of the conversion of testosterone to some of the female hormones as well, you can see gynecomastia as well as testicular atrophy in men. And then in women, you can see the opposite. You can see conversion of some of the female hormones into testosterone and a deepening of their voice as well as more body hair. And so those are obviously unwanted. Okay, so that's steroids, glucocorticoids, and mineralocorticoids. Let's take a little bit of a break and we'll go into the next lecture. Okay?